So good morning, everyone.
Good morning, ma'am.
This is a new Monday again, with the new topic, and very important topic. Almost all of our patient and almost every patient is cachexic and anorexic, and how to manage this cachexia and anorexia will be presented by Team Tata, Memorial Hospital, Mumbai. And I request Dr. Joeta to introduce speaker and moderator.
Thank you. Good morning, Sushma ma'am, and good morning,
morning.
friends. It is my pleasure to introduce Dr. Priyanka Shete to you. She's our first year resident doing MD Palliative Medicine. Her areas of interest are community-based palliative care, pediatric palliative care, and end-of-life care. Priyanka, we are still getting to know each other, so I actually don't know her extracurricular interests as yet. But what I can tell you about Priyanka is that she's a very quiet and soft-spoken girl and does her work very sincerely. And I'm sure she'll do a good job presenting this seminar. To moderate this session, we have Dr. Shamali Poojary, who is our assistant professor in the Department of Palliative Medicine. She completed her MD in Palliative Medicine, did an SR post with us, and then an SR post in KEM Hospital. She has been trained on the ECHO PPC program, as well as she has undergone the training in EPED Pediatrics training program. Her areas of interest are palliative care in lung cancer and pediatric palliative care, as well as non-oncological palliative care. So Dr. Shamali, you know since quite some time, again, an extremely astute clinician and very empathic and extremely collegial. So Shamali will moderate the session. So over to you, Priyanka and Shamali.
Thank you, ma'am.
Thank you, ma'am.
You can screen share now, Dr. Priyanka.
Yeah, ma'am.
Yeah, perfect. Go ahead.
Okay. Good morning, everyone. I'm going to present anorexia cachexia syndrome and its management. Outline of this presentation: definition, incidence, etiology, pathophysiology, stages, classification, assessment, and management. And cachexia. Cachexia is a term originated from the Greek kakos and hexis, meaning bad condition. Then why the need to know about cachexia and anorexia? Cachexia and anorexia have been recognized for a long time as adverse effects of cancer. They are associated with the reduced physical function, reduced tolerance to anti-cancer therapy, and reduced survival. Then what is cachexia? The current consensus definition of cachexia was given in 2011 by an international group of experts and accepted by European Palliative Care Research Collaborative. They defined cancer cachexia as a multifactorial syndrome defined by an ongoing loss of skeletal muscle mass with or without loss of fat mass that can be partially but not entirely reversed by conventional nutritional support. The cutoff criteria for defining cachexia are weight loss greater than 5% over 6 months, or weight loss greater than 2% in individuals with BMI less than 20, or muscle loss with or any loss of weight. Then anorexia definition. Anorexia defined as either loss of appetite or reduced calorie intake resulting in loss of weight and fat tissue. Anorexia cachexia syndrome is complex multifactorial metabolic syndrome characterized by anorexia, cachexia, asthenia, fatigue, functional decline, and change in body image. Then it is important to know difference between the sarcopenia and cachexia. The sarcopenia defined by a loss of skeletal muscle mass to standard deviation below sex-specific normal values for young adults. Unlike cachexia, sarcopenia does not require the presence of weight loss, whereas most people with cachexia are sarcopenic, not vice versa. The causes of sarcopenia are multifactorial and can include disuse, changing endocrine function, chronic diseases, inflammation, insulin resistance, nutritional deficiencies, some forms of cancer treatment, notably sorafenib and androgen deprivation therapy, and the specific cancers, notably non-small cell lung cancer. Then now coming to diagnosis criteria for cachexia. The presence of chronic disease and loss of body weight more than 5% within the previous 12 months or less, and the presence of at least 3 of the following: that is reduced muscle strain, fatigue, anorexia, low fat-free mass index, abnormal biochemistry, inflammation, anemia, and low albumin. Then anorexia and cachexia are the same? No. Anorexia and cachexia are different clinical syndromes and do not always coexist. However, they often occur together in advanced cancer and serious chronic illness. Then now coming to stages of cancer cachexia. There is a three main stages: pre-cachexia, cachexia, and refractory cachexia. In pre-cachexia, early clinical and metabolic signs are anorexia and impaired glucose tolerance. Involuntary weight loss that is equal or less than 5%. The risk of progression varies and depends on the cancer type and its stage, the presence of systemic inflammation, low food intake, lack of response to anti-cancer therapy. Then cachexia. The patient who have more than 5% loss of stable body weight over the past 6 months or BMI less than 20 and ongoing weight loss more than 2%. Sarcopenia and ongoing weight loss of more than 2% but have not entered the refractory stage are classified as cachexia. Then in refractory cachexia is characterized by a low performance status, score 3 or 4, and life expectancy is less than 3 months. Then now coming to see the incidence of percentage of weight loss with respect to tumor site. In pancreas, there is 83% of weight loss. In gastric, 83. In esophagus, 79. Head and neck, 72. In colorectal, 55 to 60. In lung, 50 to 60. In prostate, 56. Most common, 83 in pancreas. Then now coming to see etiology. Poor appetite and decreased calorie intake due to the hyperthyroidism, severe pain, gastroparesis, and early satiety, chronic nausea, depression, dysgeusia, constipation, J obstruction, hypothyroid, and mainly cancer cachexia. Then let's see the factors contributing to development of cancer, anorexia, and cachexia. First, the symptoms that may impact oral intake. These are anxiety, depression, constipation, diarrhea, difficulty in chewing, dysphagia, dyspnea, fatigue, nausea, vomiting. And the patient-related factors are body image dissatisfaction, eating-related stress, fatigue, early satiety, loss of appetite. Then third one is disease-related factors, that is side of tumor, weakness, disability, uterine imbalance, obstruction, malabsorption, impaired gut function, inflammatory cytokines. And treatment-related factors are mucositis, nausea, vomiting, altered taste or smell, adrenal insufficiency, hypogonadism, hypothyroidism, sarcopenia from cancer treatment like androgen deprivation therapy, like sorafenib, prolonged high dose of steroids. Then now coming to this pathophysiology. In pathophysiology, the human body responds to stress with dramatic resilience and ultimately aims to maintain hemostasis. Second one is inflammatory mediators contribute to both reduced food intake and activation of catabolic process. Then cachexia characterized by a negative protein and energy balance, driven by a variable combination of reduced food intake and abnormal metabolism. Then there is a flow chart for the pathophysiology of cachexia. In this, first we see the neuroendocrine response. In this, increased adrenergic activity, increased cortisol, decreased insulin, hypogonadism, increased renin-angiotensin system activity. Then second one is anorexia. There is two types, primary anorexia and secondary anorexia. In primary anorexia, there is a natural disinterest in eating neurohormone mechanism, which includes the molecules like neuropeptide Y, melanocortin, leptin, ghrelin, melanin coenzyme A, serotonin, cytokines, glucocorticoids. And in secondary anorexia, reversible causes like anxiety, depression, intestinal obstruction, nausea, vomiting, constipation, alteration in taste, persistent pain. Then third one is hypermetabolism due to the increased resting energy expenditure. Then muscle catabolism pathway, in this down regulation of myosin heavy chains by cytokines and tumor specific factors. Tumor specific factors like proteolysis inducing factor and lipid mobilizing factor. Then last is cytokines. In cytokines, there is a procachetic cytokines and anti-cachetic cytokines. In procachetic, TNF alpha, interleukin 6 and 1, interferon gamma. And in anti-cachetic, interleukin 4, 10 and 13. Then let's see the neurohormonal regulation, the signaling molecules that influence appetite regulation by positive effect and negative effect. In positive effect, glucocorticoids, dopamine, ghrelin, orexin A and B, endocannabinoids, neuropeptide Y. And in negative effect, alpha melanocyte stimulating factor, serotonin, leptin, tumor necrosis, factor alpha, pro-opiomelanocortin, thyrotropin releasing hormone. Then the FA for muscle atrophy. It is a tumor which activates the pro-inflammatory neuroendocrine responses, resulting in reduced food intake and metabolic change. Then adrenergic activation and tumor-related lipolytic factors lead to enhanced lipolysis. The effects of hypogonadism, insulin resistance, adrenergic activation, and systemic inflammation coupled with semi-starvation. Then muscle atrophy. Then now coming to clinical presentation of anorexia cachexia syndrome. The signs and symptoms in cachexia assessment, including secondary nutrition impact symptoms. First, the symptoms related to underlying disease are appetite loss, early satiety, weakness, and disability. Then secondary nutrition impact symptoms that may impact oral intake, calorie intake, are anxiety, depression, constipation, diarrhea, difficulty in swimming, dysgeusia, dyspnea, fatigue, nausea, vomiting, pain. Then symptoms that might be a consequence of cachexia are body image dissatisfaction, eating related distress, and fatigue. Then other contributing factors are adrenal insufficiency, hypogonadism, hypothyroidism, sarcopenia from cancer treatment like androgen deprivation therapy, sorafenib, and bevacizumab. Then let's see the assessment of anorexia cachexia syndrome. First, anorexia, reduced food intake, catabolic drivers, muscle mass and strength, effect of cachexia on the patient. Then in first, anorexia and reduced food intake, look for the underlying factors. This includes decreased central drive to eat, chemosensory disturbances like in taste, example in taste and smell, decreased upper GI motility leading to early satiety and nausea, dystotic dysmotility and food intake. Then catabolic drivers, variable component of cachexia is hypercatabolism caused by tumor metabolism, systemic inflammation, or other tumor-mediated effects. The most widely accepted index of systemic inflammation is the C-reactive protein. Then third one is muscle mass and strength. It can be assessed using the cross-sectional imaging like CT and MRI, dual energy X-ray imaging DEXA, anthropometry, mid-arm muscle area, bioimpedance analysis, muscle strength testing, which includes upper limb grip, hand grip, dynamometry, and the lower limb extension strength testing. Then let's see the functional and psychosocial effects. It is assessed using ECOG, KPS, or patient-reported quality of life scales like European Organization for Research and Treatment of Cancer, that is EORTC, and quality of life questionnaire C30 and FAACT. Then let's see the ISMO guidelines for assessment. In these guidelines, parameters of comprehensive cachexia assessment and recommendation tools are given. We see the category wise. In first category, nutritional status. For nutritional status, parameters like whole body status, weight loss, food intake, recommended tools like body weight, anthropometry. Then second category, metabolic status. In this, recommended tools are modified Glasgow prognostic score. Then third is functional status. In this, we parameters use are performance status, physical activity dependency, and in recommended tools are ECOG, WHO index, ADL. Then in nutritional barriers, parameters are nutritional impact symptoms, which can be recommended tools are PGSCJ, nutritional impact checklist. And for GI dysfunctions, diagnostic interview imaging test, functional test, visual analog scales are recommended. Then distressing symptom, for distressing symptom, ISAs commonly used. Then psychological and social distress, FACT and EORTC can be used. The adverse events of medication recommended are pharmacological counseling, and for tumor status, oncological counsel are recommended. Then briefly know about the patient-generated subjective global assessment. In this, 5 worksheets are there, and the categories are stage A, stage B, and stage C. Then the second one is functional assessment of anorexia cachexia theory questionnaire. In this, we see for physical well-being, social family well-being, emotional well-being, functional well-being. Then there is a paper for validation and real-world assessment of a functional assessment of anorexia cachexia therapy scale in patients with advanced non-small cell lung cancer and the cancer anorexia cachexia syndrome, which conclude that in patients with non-small cell lung cancer, the FACT and its assays perform well compared with the other instruments, further supporting their validity and value in clinical research. FACT and assay scores correlated with the symptoms and other quality of life changes that are typically hallmarks of CACs, lending further support to their use of quality of life endpoints in clinical trials among the patients with CACs. Then now coming to the main part of our presentation is management. Then there is a no standard consensus upon the assessment of cancer cachexia. The assessment of cachexia includes objective as well as subjective measures, and the goals of management in palliative care setting is to provide maximum subjective benefit over patients' presenting status. The assessment of cancer cachexia should be multidimensional and should done in each patient. It is important to determine the overall condition of the patient and decide best possible treatment plan. Then first we see the overall intake. The average daily calorie deficit in weight losing cancer patient is of the order of 250 to 400 kilocalorie per day. Maintain protein intake at high level to either stabilize or replace diminished skeletal muscle mass. Protein intake should generally be maintained between the 1 to 1 gram per kg per day. Then exercise. Oncology nutrition clinical practice guidelines now include recommendation for exercise in combination with nutrition, that is maintenance or increased level of physical activity in cancer patient to support muscle mass and physical function. Daily exercise is important to counteract muscle wasting. Then there is a paper for a framework for prescription in exercise oncology research, which concludes that the prescription is individualized to the patient based on baseline cardiorespiratory fitness and or muscle strength status. Then for in progressive overload, the exercise sessions are progressively increased in intensity and duration. Hence, the training stress is increased across the intervention. Then in recovery, appropriate rest and recovery sessions days are incorporated between the training session to optimize physiological adaptation. Then in specificity, prescription is specifically designed to induce the improvements in the primary outcome. Then now coming to the medical management. In medical management, we first see the appetite stimulants. Example, megestrol acetate. Megestrol acetate is a progesterone derivative, predominantly progestational and anti-gonadotropic effects. The start for short course, discontinue drug if no effect within 2 weeks. Megestrol acetate 80 to 160 mg per oral each morning. If response poor, consider doubling after 2 weeks. Maximum dose generally 800 mg per oral in 24 hours. Gain of weight associated with the megestrol acetate treatment is composite of fat mass. Megestrol acetate also induces catabolic losses of muscle mass. In studies of cancer cachexia, megestrol acetate associates with the higher rate of deep venous thrombosis than dexamethasone, which is better to avoid in DVT. Then there is a Cochrane database systemic review on megestrol acetate for treatment of anorexia cachexia syndrome. The author's conclusion is this review shows the megestrol acetate improves appetite and is associated with slight weight gain in cancer, AIDS, and in patients with other underlying pathology. Despite the fact that these patients are receiving palliative care, they should be informed of the risks involved in taking megestrol acetate. Then there is a systemic review and meta-analysis of the clinical use of megestrol acetate for cancer-related anorexia and cachexia. The conclusion is megestrol acetate did not produce significant weight gain in patients with advanced cancer. There was also no difference between the patient who received high dose and low dose megestrol acetate. Megestrol acetate also did not appear to be. Then second one is corticosteroids. Guidelines recommended that a short-term trial of corticosteroid may be offered for appetite stimulation in patients with advanced cancer using dexamethasone 3 to 4 mg per day per oral or equivalent, with the duration of treatment dependent on the treatment goals and the assessment of risk versus benefit. Then corticosteroids were the subject of 6 studies in the Vauzes et al. Review. 3 trials in 402 patients used methylprednisolone orally or intravenously IV at doses 32 to 125 mg per day for 1 to 8 weeks versus placebo. Significant improvements were seen in appetite and quality of life, but not weight. One trial in 61 patients involved prednisolone 10 mg per day for 6 weeks. Compared with placebo, appetite and well-being were significantly improved. Then 2 trials in 184 patients used dexamethasone 3 to 8 mg per day for 4 days or until time of death. A transient improvement in appetite compared to placebo was seen. Due to their well-known adverse effects, particularly with longer duration of use, corticosteroids may be more suitable for patients with short life expectancy. And then third was NSAIDs. It is presently suggested that they are insufficient consistent clinical to recommend NSAIDs to improve weight loss. There is a need for more high quality research. Then there is a systemic review, non-steroidal anti-inflammatory drugs for the treatment of cancer cachexia. that concludes that insufficient studies have been performed to allow a conclusion to be formed that regard to the effectiveness of NSAIDs in the treatment of cachexia and advanced cancer. Major challenges in this patient cohort include the lack of uniformity of conclusion criteria across the studies and the plurality of patients recruited. Then omega-3 polyunsaturated fatty acids like EPA and DHA, European Association of Clinical Nutrition and Metabolism guidelines recommend that the patient in advanced cancer undergoing chemotherapy, dietary supplementation with long-chain omega-3 fatty acids or fish oil is used to stabilize or improve appetite, food intake, lean body mass, and body weight. A total dose of 2 to 2.2 gram per day total EPA plus DHA is recommended, but there is insufficient data to routinely prescribe these. However, recent meta-analysis on oral nutritional supplements in patients receiving active treatment, that's chemotherapy and chemoradiotherapy, showed a significant weight gain in patients on high-protein fish oil enriched oral nutrition supplements compared with the isocaloric controls. The neuroagents, ghrelin neuropeptide in the brain where it is regulates appetite and metabolism, enamoring a growth hormone secretagogue receptor type 1, ghrelin receptor agonist. Then there is a Romana 1 and Romana 2 studies where randomized double-blind placebo-controlled phase 3 trials done at 93 sites in 19 countries, patients with inoperable stage 3-4 non-small cell lung cancer and cachexia. The interpretation is enamoreline significantly increased lean body mass, but not hand grip strength in patients with advanced non-small cell lung cancer, considering the unmet medical need for safe and effective treatments for cachexia. Enamoreline might be treatment option for a patient with cancer, anorexia, and cachexia. The studies is ongoing. The final result is not yet come. Then enobosarm, the selective androgen modulator, a new class of non-steroidal tissue-specific anabolic agent. The drugs appear to be well tolerated. Then spironolactone. It is a non-selective beta blocker and with central 5-hydroxytryptophan type 1A and partial beta receptor agonist effects. A single randomized double-blind placebo-controlled phase 2 multi-center trial was conducted in 87 patients with advanced colorectal and non-small cell lung cancer-related cachexia. Then thalidomide. Thalidomide inhibits tumor necrosis factor alpha by Reed Cochrane 2012 completing a study says that the insufficient evidence to refute or support the use of thalidomide for the management of cachexia in advanced cancer patients. Then amino acids. Ernst et al. 2017 concluded that there are insufficient consistent clinical data to recommend that supplementation with amino acid. The specific amino acid is glutamine, L-carnitine. This transports fatty acids, improve the lean body mass. Then next, cannabinoids. Cannabinoids has a well-defined orexogenic effect and has the unique ability to enhance hedonic appeal of food. A Cochrane-driven meta-analysis of cannabinoids in palliative medicine rated the quality of evidence comparing cannabinoids with placebo in studies with a randomized placebo-controlled design as a very low because of indirectness, imprecision, and potential reporting bias. In meta-analysis of 3 studies, including the total 706 cancer patients, there was no significant difference between and the placebo for improving calorie intake or appetite. Then there is a paper, systematic review and meta-analysis, cannabinoid interventions for improving cachexia outcomes in cancer. The conclusion is there with no high quality evidence, no recommendation can be made to support the use of cannabinoids alone to improve symptoms and outcomes in CACs patient. Multimodal therapies integrating cannabinoids alongside other treatment strategies may have a greater potential. Without better data, identifying the investigation or the nutritional and pharmacological intervention may provide more conclusive findings. Then mirtazapine, a tetracycline antidepressant, has been associated with the weight gain but was not better than placebo at improving appetite in trial among patients with cancer-associated anorexia and cachexia. There is paper by Richardman, phase 2 trial of mirtazapine for cancer-related cachexia anorexia, which concludes that mirtazapine appears to be a promising therapeutic agent for management of cancer-related cachexia and anorexia, but further research is required to substantiate these findings. The randomized trials are warranted to examine the role of mirtazapine on weight, appetite, high quality of life patients suffering from this fashion. Then olanzapine. Olanzapine is a typical antipsychotic drug acting on multiple receptors, including dopamine and serotonin receptors, both of which are potentially relevant in cachexia. The clinical use olanzapine causes more weight gain than other antipsychotic agents. The randomized double-blind placebo-controlled study of the olanzapine for chemotherapy-related anorexia in patients with locally advanced or metastatic gastric hepatopancreatitis and lung cancer. The conclusion of this is low dose, that is 2.5 mg once daily olanzapine is simple, inexpensive, well-tolerated intervention that significantly improves appetite and weight gain in newly diagnosed patient on chemotherapy. Then well supported by evidence for progestins and corticosteroids, limited supported evidence for ghrelin, envaosome, spironolactone, no evidence for thalidomide and cannabinoids. Then now coming to the multimodal therapy, the complexity of cancer cachexia lead to multimodal approach targeting its multiple facets, and that this is like to be optimal approach. The rationale is that the food intake and exercise show synergy in their effects. In ongoing clinical trials of cancer cachexia therapy, multimodal intervention is formalized, including nutritional therapy, anti-inflammatory interventions, and exercise therapy. This studies provided some evidence that combination therapies can improve lean body mass function, but further studies are required to verify the findings. Then we briefly see the multimodal modality treatment model. It is a tumor host infection causes increased pro-inflammatory cytokines, poor appetite, endocrine dysfunction, and elevated resting energy expenditure. For increased pro-inflammatory cytokine, there is a specific treatment interventions like thalidomide, interleukin inhibitors, fish oil, NSAIDs. Then for poor appetite, ghrelin mimetics, minestrol, corticosteroids. For endocrine dysfunction, androgens, insulin. Then elevated resting energy expenditure, beta blocker. And in general, there is treatment intervention is exercise, nutritional counseling, control of nutritional impact symptom. Then there is one paper by Tora Solheim that randomized phase 2 feasibility trial of multimodal intervention for the management of cachexia in lung and pancreatic cancer. The conclusion is the multimodal cachexia intervention is feasible and safe in patients with incurable lung or pancreatic cancer. However, compliance to nutritional supplements was suboptimal. A phase 3 study is now underway to assess fully the effect of the intervention. Then let's see the guidelines for the management of cancer cachexia. First, we see the ASCO guideline. Recommendations are dietary counseling may be offered with the goals of providing patients and caregivers with advice for the management of cachexia. Enteral feeding tubes and parental nutrition should not be used routinely. In the absence of more robust evidence, no specific pharmacological intervention can be recommended as the standard of care. Therefore, clinicians may choose not to prescribe medication specifically for the treatment of cancer cachexia. Nonetheless, when it is decided to trial a drug to improve appetite and improve weight gain, currently available pharmacological interventions that may be used include progesterone analogs and short-term corticosteroids. Then in ASCO guidelines, there is a dietary counseling, progesterone analogs, corticosteroids are moderate in favor. Then anamorilin, olanzapine, androgens, thalidomide, NSAIDs are not recommended. Then see the ISMO guidelines. In ISMO clinical practice guidelines, we see the invasiveness of interventions related to expected survival. There is a probability of survival and focus of care. In this more than few months, that is 3 to 6 months, focus of care is regular screening and nutritional intervention if and when required. Then in less than few months, focus of care is decreasing invasiveness of nutritional interventions and preference for counseling and oral nutrition supplements. Then less than few weeks, focus of care is comfort directed care and relieve eating related distress and thirst if present. Then third one is NCCN guidelines. In these guidelines, we see the life expectancy. In life expectancy, if it is in years to months, for depression and anorexia, mirtazapine 7.5 to 30 mg per oral QH is recommended. Then in gastroparesis, metoclopramide 5 to 10 mg per oral QID 30 minutes before meals and the bedtime is recommended. Then low and no appetite, minestrol acetate 400 to 800 mg per day per oral or olanzapine 5 mg per day per oral is recommended. Then there is a life expectancy in months to weeks or weeks to days, like in dying patient, low or no appetite, minestrol acetate 400 to 800 mg per day per oral or olanzapine, then or dexamethasone or considered cannabinoid recommended. Then for in depression, metazepam 7.5 to 30 mg per hour QHS. Then we compare the three guidelines. In this, first we see the steroids. For steroids in ESMO guidelines, corticosteroids may be used to increase appetite for a short period up to 2 to 3 weeks. Then according to ASCO guidelines are moderate in favor. In NCCN guidelines, can use if life expectancy months to week. For magistral acetate, ESMO guidelines says progestins may be used to increase appetite and body weight. ASCO guidelines are moderate in favor. Then NCCN guidelines says can use if low or no appetite life expectancy is in months to weeks. And for olanzapine, in ESMO guideline there is a moderate evidence. ASCO guidelines no recommendation. NCCN guidelines can use if life expectancy months to weeks. Then for dietary counseling, ESMO guidelines recommended it. ASCO guidelines moderate in favor. No comment on dietary counseling in NCCN guidelines. Then metazepam. For metazepam, ESMO guidelines no recommendation. ASCO guidelines no recommendation. NCCN guidelines says can use if associated with the other symptom like depression. Then lastly, we see the NCG palliative care guidelines for anorexia cachexia. In this, we see the approach to managing cancer-related anorexia cachexia syndrome. In this, patient with significant weight loss, muscle loss with functional decline, it is important to know the clinical history and examination are the reversible contributors. In this, is it really CACs? Rule out the differential diagnosis like starvation, age-related loss of muscle mass, malabsorption, hypothyroidism. Then cachexia with reversible contributors like comorbidities. In comorbidities like anemia, dehydration, hypercalcemia, hyponatremia, uremia, then autonomic neuropathy, infection. Then the treatment and drug contributing to reduce intake like antibiotics, chemotherapy, radiation. Then all dietary advice and nutrition is tailored to patient's habits and culture. Then second one is transient reversible phase in the trajectory of care. Patient in post-op stage, head and neck cancer on combined CTRT, reversible bowel obstruction, short bowel syndrome, incurative interim chemotherapy, decision as on case-by-case basis. In this is gut functional enteral NG tube, PEG tube feeding is recommended. The total parental nutrition as informed shared decision. Then last is no reversible conditions, not responding to conventional nutrient support and worsening weight loss. In these two cases are there. First one is stable disease, adult function preserved, ECOG is less than 3, prognosis ambiguous. In this, shared decision made on a case-by-case basis based on risk versus benefit, preferences, life stance, and adverse care plan is important. In this, propensate care intensive feeding. Then TPN and subgroup of highly selected patients review risk benefit after a pre-planned interval. Then last is refractory CACs, unresponsive disease, ECOG is more than 3, progressive deterioration, poor functions, and prognosis less than 3 months. In this case, best supportive care is recommended. Then take-home message. In this, management needs to address both the reduced nutritional intake and the abnormal host metabolism. That is, multimodal approach is important. The importance of early identification and intervention, and the recognize that once cancer cachexia is advanced, response to treatment is unlikely, and that the focus on these circumstances should be on symptom relief and psychosocial support. Thank you.
Thank you, Dr. Priyanka. We can take any questions if there are any.
Dr Shamali, would you like to take up the now, summarize?
Yes, ma'am.
Hello.
So to summarize, like Dr. Priyanka said, it has to be individualized and multimodal approach should be considered. So in case of refractory cancer-associated anorexia, cachexia, the focus should be providing symptom control rather than trying to treat the anorexia, cachexia. So we don't really have any drugs which have very good quality evidence to show for use in anorexia, cachexia. Something that we commonly use is dexamethasone, magistral acetate, Anamorelin is another good drug which has shown some evidence in the Ramona trials. However, it's not available in India, and even if it was, it is very costly. So basically, to summarize, it has to be individualized, and we have to focus on the symptom.
There's one question, Shamli, if you want to take that. About fat-free mass index, is it the same as lean body mass?
Yes. So they are usually interchangeably. They almost are similar concept, but lean body mass is the mass that actually provides us with the energy and which helps us in the metabolism. So
Any other question or comments from anyone? Dr. Jennifer, would you like to comment on this important topic of your pulse? This is a very important topic and everybody should be handling every day.
Thank you, ma'am. Yes, it is a very common problem, but the evidence around this is very little in terms of pharmacological treatment. I think Priyanka has covered the existing evidence. What is important, going back, I always like to go back to history and the impact of symptoms on patients. So the impact of this particular symptom on the physical thing may not be, they might just say loss of weight, loss of appetite, but what is the impact of that in their psychological, social life is very important, because many of them, the clothes they wear will be loose. The family, when they look at them, will find them difficult. For the patient himself or herself, often they have showed pictures, their previous photographs, and said, this is how I used to be and this is how I am now. So all these things have to be acknowledged, have to be spoken about. Definitely, like Shamali mentioned, the pharmacological treatment we have is again corticosteroids and megestrol. Somebody has also put in the chat. So among the different pharmacological treatment, the other thing is mirtazapine would be one of the drugs which get listed among the polysymptom management. So if there is it has some evidence for weight gain and appetite increase. The other thing is definitely handling the family members who are obviously very upset, and there is an underlying thing between patient and family about food intake and all that. So the explanation and the non-pharmacological management should be definitely emphasized along with that. Thank you very much.
Thank you, Dr. Jennifer. Very important points you have covered. There are 3-4 questions. Shamli, if you want to take up these questions.
yes.
Can you see the questions, please?
So Preeti asked how to manage anorexia at end of life and in hospice setting. So unfortunately, we don't have any guidelines for end of life management of anorexia, cachexia. Again, like Jennifer ma'am said, the focus has to be management of symptoms and the psychosocial distress of the patient and the family. However, you can consider trying dexamethasone here. We really don't have any evidence on how much it is actually going to benefit at that point. What is the maximum dose of mirtazapine for appetite stimulation and how long does it take to see the benefit? So 7.5 to 30 mg per day is what the NCCN guidelines says. How long does it take to see the benefit? So actually, studies have not really suggested that there is any significant benefit with mirtazapine. So unfortunately, I cannot answer that question. If someone else knows it, can please help here. So what is the dose and duration of use of dexamethasone for cancer cachexia? Dexamethasone is a steroid, so should be used for short term, if possible. So a trial of 2 weeks to see if there is any benefit, and then you taper it off. Mirtazapine, no benefit. Yes, true, ma'am. Thank you, ma'am. So mirtazapine, no benefit unless there is depression and other symptoms. In patients with more life expectancy, can overuse of antacid lead to anorexia? With dexamethasone, which antacid can be combined? Unfortunately, I'm not sure of the answer if antacid can lead to anorexia. Which antacid to combine with dexamethasone? The dexamethasone is usually given under the cover of any PPIs. So, pantoprazole, omeprazole, esomeprazole, ranitidine, famotidine, if you prefer those ones. However, I'm not sure if antacid can lead to anorexia. Sorry.
Just to add on, Shamali, so this about
Yes, ma'am.
mirtazapine, yes, we don't have big studies, but mirtazapine, it's among the different actions it has, including for depression, insomnia, appetite stimulant. It says what literature says is it can be used as an off-label drug. So we don't have evidence, but in situations where we really don't have much to do in terms of anorexia cachexia, this can be as an appetite stimulant. This can be tried. Basically, the adverse effect of mirtazapine acts as something which is helpful. It causes increase in appetite, not in everybody, maybe 15 to 20% of patients. So that is how that helps. Thanks. And even in about corticosteroids, it does not have a long-term benefit and should not be given long-term as an appetite stimulant. So like you mentioned, it's only for a try for maybe a week or two maximum and see the benefit and stop. Thanks.
Thank you, ma'am.
Thank you, ma'am.
So anyone wants to comment because we have time? Anyone has any comment?
Sorry, there's one more question from Divya Sai about TPN.
So, total parental nutrition, again, contradicting evidences on total parental nutrition. So what we suggest is again individualize it to the patient. It depends on the performance status. If any disease modifying therapy is going to be planned, it depends on the reason why you want to start total parental nutrition. So total parental nutrition for anorexia cachexia, no evidence. So you'll not do that unless you have some other reasons like bowel obstruction, or it is radiation induced severe mucositis needing a short term of total parental nutrition, and things are going to get reversed. If it's bowel obstruction, plan for disease directed treatment or surgery and things are going to get reversed. So in such cases, you discuss it with the treating physician, you discuss it with the family, you discuss it with the patient if possible, and have a consensus on whether you want to start TPN and how will you continue the TPN, because home-based TPN is something that is very difficult to maintain. So you need to have the discussion with the family.
So I think this was a very good discussion. Everyone has, I think the evidence which Priyanka has given, I think they were quite latest evidence, and we have covered almost all the important points, but I think this is very important, which Dr. Jennifer has given the ultimate message that we have to keep working, and every patient, and I think this is my own experience, that every patient is different. Sometimes they are just simply because they are depressed, and if we to talk to them properly, if we make them understand that what is happening, uh, they start eating. But if there is any kind of a pathology, I think steroids, dexamethasone and magistol, at least we should know how to use it. And other medication, we should keep trying, and we should keep creating evidence. Thank you very much. And Gita says that TPN has a lot of complication. Yes, TPN is not a, we don't recommend TPN for anorexia cachexia, definitely. Would you like to speak, Ajita? Otherwise, what do you want to say? Okay, otherwise, thank you very much. We will see you next week before 6:30. Thank you, Anuj. Thank you, Shamali, Priyanka, and Dr. Joeta. And thank you, Dr. Jennifer. Thank you, Archana and Nisha. Thank you very much. And thank you,
Thank
everyone,
you.
for joining.